Welcome to Colorectal Cancer's Canada's Ready for the Next Round. My name is Anne-Marie Wright, and I am privileged to be the host and moderator of this critically important initiative. The mission of the initiative is clear: to raise awareness on the importance of uninterrupted colorectal cancer screening and treatment, and to find strategies for strengthening health system resilience. This is the first of 4 thought leadership roundtables, each representing the views of 4 different stakeholder groups that colorectal cancer is leading. We want to hear firsthand experiences from patients, physicians, healthcare system leaders, and researchers to identify new solutions and ideas for colorectal cancer care across the full continuum. On behalf of Colorectal Cancer Canada, I would like to thank the amazing sponsors of this initiative. We are grateful to Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Merck, Novartis, and Pendopharm. And a very large thank you to all of our participants today, and we'll ask you to introduce yourself in a moment. What are we aiming to accomplish with Ready for the Next Round? Let's play a short video that will set the stage for today's conversation. Maria, I might add that we do not have sound on the video. I think we'll try again. Even though we practiced this several times, here we go.
The best chance to beat cancer is to treat the patient when they're at the early stage of disease. You want to get it early and you want to treat it early.
So when COVID hit, cancer screening was interrupted. Because of the interruptions on these screening programs, people will miss their chance for an early diagnosis. They'll find out they have cancer when it's already progressed to a later stage.
Amongst my patients, there have been longer than usual waits to get a diagnosis of cancer, and that means a longer time than usual to get the appropriate evaluation and treatments that they need. It's extremely important for the healthcare system to be ready to deal with the next crisis.
We need to be innovative, collaborative. We will need streamlined solutions with new technologies to be more efficient. Collaboration is going to be key. We all have to work together to get past this and get past the next crisis that's sure to come.
Our preparation needs to begin right now.
Perfect, thank you so much. So simply stated, COVID delayed the fight against cancer. We need to be ready for the next crisis. Being ready is not about bouncing back to the pre-Canadian system, but evolving into something better and stronger. The goal must be to provide and build a sustainable system that is able to respond to future system shocks, be prepared for longer-term planning, and undertake positive actions, taking into account the benefits and risks of both the general population and patients. Today, colorectal cancer has assembled an expert roundtable of patient stakeholders, including patient groups, caregivers, and patient survivors. Please note that this session is being recorded and that a report writer has been secured to capture all of the excellent conversation that will happen today. So without further ado, I'd like to begin with some brief introductions. And because Gary, you're on my top left-hand screen, may I ask you please to introduce yourself, simple statement about who you are and where you're from.
name is Gary Pupa. I'm based in Ottawa here.
Welcome, Gary. Robin?
My name is Robin McGee. I've been a stage 4 colorectal cancer patient for 11 years this year, and I'm in Nova Scotia and in the
Tell
national
them where
park.
you, yeah, I was going to say, tell them where you are, Robin. It's exciting.
I'm in Kedjamakuji.
Great. Thank you, Robin. Karine.
Hi, my name is Karine Chelly-Four. I'm the program director with Young Adult Cancer Canada, and our office is in Newfoundland. So I'm in St. John's, Newfoundland.
Ah, fantastic. So we've got the East Coast covered, I think, so far. Hannah, welcome. I love the blue
thank you so much.
boxing gloves in the background. I know what those are for.
Absolutely. Nice to be here. Thank you. So my name is Hannah Cohen. I'm a patient support counselor at Colorectal Cancer Canada, and I'm based here in Montreal.
Tell people what the blue gloves are for.
The blue gloves, well, so it's a bit controversial when people talk about battling cancer and fighting, but I am also a stage 3 colon cancer survivor, and very very enamored with kickboxing. So these just kind of go with that.
That's fantastic. Yeah, thank you so much, Hannah. Welcome. Nana.
Hi, I'm Mana Westcott. I'm actually on the other coast. I'm on Vancouver Island, kind of mid-island, so I'm a little bit remote. I'm not in a big city. I was diagnosed in 2019 with stage 4 colon cancer in my sigmoid, and it was metastasized to my liver. I was diagnosed at 42.
Welcome, Mana. Whereabouts on Vancouver Island? I know it well. My husband grew up there.
Okay, I'm in Courtenay, so the Comox Alps.
That is stunning. How lucky are you to be there? Yes. Thank you so much, Mana. Eva, nice to see you. Welcome.
Hi, I'm Eva Vlaba. I'm the executive director of the Quebec Cancer Coalition, and I'm in Quebec and Montreal.
Thank you for joining today. Cheryl Ann, hello.
Hi, thank you for allowing me to join today. I'm 47 years old. I was diagnosed with colon cancer in January 2021. So I'm in the midst of my battle. I'm in Keswick, Ontario, and looking forward to this conversation.
Yeah, thank you so much for joining us today. And Natalie, hello, welcome.
Hi, everybody. Thank you for inviting me. My name is Natalie Leon. In Montreal, I'm known as an infirmière pivot. In the rest of Canada, it's a nurse navigator. I've been with the colorectal tumor site for about the last 3.5 years, and I'm located in Montreal.
Yeah, great. Thank you so much. It is particularly gratifying to have a healthcare professional such as yourself join us today in these times. Thank you. So we have about 2 hours together, and there was 5, let's call them exploratory areas that we want to get into. I encourage all of you to share your firsthand experiences. There's no right or wrong answers. This is really to gain your thoughts, your ideas, your experiences on how you've experienced the healthcare system, particularly during COVID, but most importantly, how we want to look towards the future and make changes to the system in very positive and proactive ways that can help people like yourselves in new and fresh ways. So let me start with a very broad-based opening question, and then we'll get into some of the conversation here. There's actually a significant amount of literature that has suggested that the pandemic has had a major impact on cancer care across that full continuum, that continuum being prevention and screening, diagnosis, treatment, survivorship, end of life. And in broad terms, I would like to have a brief discussion from each of you on how you were impacted by COVID, whether it be from a treatment perspective, a prevention perspective, and particularly related to your colorectal cancer. Eva, I hope you don't mind. I would really very much like to start with you because you have a broad perspective on patient groups, and you could just help summarize some of the general impacts. That would be a great starting place.
Sure. One of the things that we're very concerned about is in the first waves of COVID, when everything shut down, and then we really got to see what the healthcare system considered to be a priority. And we saw that prevention was not a priority, that early diagnosis was not a priority, and even clinical trials were not a priority. All of these, and imaging. So all of these really essential to having a good outcome, all of these essential services to having a good outcome for patients were not considered a priority. Only the most urgent surgeries were considered a priority. So if you were lucky enough to already have been in the system at the time and your case was bad enough, then you were seen. And so I think that the impact was that a lot of people that really needed to just get seen by the appropriate healthcare professionals at the right time kind of fell through the cracks in that first stage. And we know that in Quebec, to my knowledge, it's the only province that actually measured the impact of that first wave on increasing cancer cases. And they have estimated that just from April to June of 2020, we missed over 4,000 cancer cases. And a lot of that, because we do have a program that can catch colorectal cancer early with a FIT test and with colonoscopies, we do believe that they were very heavily impacted. And so we're concerned about the impact that will have. And now there's waiting lists to get colonoscopies, to see a primary care doctor, people that, thought about going and get checked for their symptoms were kind of waiting for this whole thing to end. And, it kept dragging on. And so, so these are the things that we're concerned about, is that, not catching people in time. And then how will we, and I know this is going to come up later, but how will we be able to address that as quickly as possible so that no one has to suffer from the collateral damage of these stoppages. I know that there's many people here that aren't necessarily in urban areas, and that's always a concern as well, is yes. We can't just take care of, the postal codes in urban regions or the few provinces that have, lots of university health centers, but how do we ensure that it's the most equitable possible? And because COVID exacerbated some of those health inequities, that's also something that we're very concerned about.
Yeah. Thank you for setting the stage and many, many springboards from that, Eva, from your perspective. Robin, I saw you nodding quite a bit. Tell us about your personal experiences.
So as I said, I've had stage 4 for 11 years, and it's been marked by periods of recurrence and patches of no evidence of disease. And anyway, I learned that my cancer had recurred on the day the pandemic was declared here in Nova Scotia on March 17th. So unfortunately, what that meant for me was that I couldn't even access the cancer care system by phone. So I got the diagnosis through my family doctor calling me saying, yeah, your blast PET scan said it's back. And then I tried to initiate. I had been in the system previously, so I wasn't a novice to it. And yet it took me ultimately 3 months to access chemotherapy and over 5 months before I could even speak to a surgeon, which I did on the phone. So that was compared to my pre-COVID cancer experiences, those kinds of interventions would have happened within a month. So it was significantly delayed, despite being a known cancer patient, and this is a recurrence that was entirely predictable based on
because you'd been living with cancer for some time. Did that create extra stress, extra worry?
Yeah, no, I think the worst part of it was the psychological part, because it's one thing once you have as a treatment plan and you're on it, but to not have any plan and to have none of your providers able to get back to you and not be able to reach them, and meanwhile you can feel this thing getting worse and growing. There's your pain just keeps escalating, and you can't break in. You just couldn't get traction. And that's despite email, phone calls, Twitter, a number of other things.
Well, thank you for going there, because that's exactly what I wanted to, because you're perhaps experienced with the system, given your time of having cancer. Was there out of the ordinary, extraordinary steps that you took? Twitter was an interesting comment you made.
Yeah, so when I hadn't heard after about 2 weeks, I ended up tweeting the head of the health authority here in Nova Scotia saying, can you help me? Can you help me make contact with someone? Even if it's just, yes, we know about your recurrence. We'll get back to you eventually when we're able to. There was nothing. There was no attempt to reach newly diagnosed people to say, we see you, we'll get to you when we can. There was no reassurance of any kind. So that, from my perspective, was something that could have been done differently. Of course, it's all hindsight's 2020 is.
Yes, and you did not
yes,
get a response.
No pun intended.
You got no response from the health authority at the time?
No, they did respond. The health authority person responded to my tweet saying, I will arrange for someone to reach you. Someone reached me. I said, I haven't been able to get through to the providers. What that person was able to tell me was what some of the horrible roadblocks were at the NSHA's end. So for example, it was March. So it was March break. So many oncologists had traveled south or traveled to different countries for their March break holiday, which is the same as yours in Ontario. And then they all had to quarantine when they came back, so they couldn't see patients. So there was like one person seeing all of Nova Scotia and all of PEI. So it was truly impossible from a healthcare delivery perspective. So, I completely understand. I'm completely forgiving about that kind of a delay, but as your video showed, the system wasn't ready.
Yeah, thank you. That's an extraordinary story. Cheryl Ann, would you like to share?
I'm on the opposite end of Robin's story. I had amazing care. I was diagnosed just as the second wave was hitting its peak. We had just moved to Keswick. I didn't have a family doctor, so I was also dealing with walking clinics. I was able to get appointments rather quickly. The day actually I had my ultrasound to find that I had a blockage, they called me by 5 o'clock that evening, and I was in emergency by 7.
Nice.
And I had a surgeon at my bedside before 10:30. So I had the complete opposite. The care that I've had through my journey, I ended up having surgery a couple of days later, had home care coming to my house, that was set up. All my calls have been virtual. I haven't had the extra anxiety of getting dressed, going into a hospital. I've been able to do all my oncology visits over the phone. Lab stuff has been relatively easy for me. So I'm complete opposite from what most people think. So I'm truly fortunate, but I do see gaps for people that were not as fortunate as I was. Mine was an emergency situation. I had other friends that weren't in the same crisis as I was in that did see the delay.
Yeah. So you would say, Cheryl Ann, because you were in crisis, that's what really expedited the process.
Yes, the crisis was handled very well, but I think just coming in, having blood tests done, regular testing through doctors, my friends saw delays.
Wow, very interesting. Thank you. Is there someone that would like to go next? Just put your hand up and I can see all of you, which is great.
I'll go
Yes. Next. Oh, all right, Gary, thank you.
Okay. Sorry, I was a bit nervous in the opening, so I'll tell the rest of my story. So last October, I did not know how to spell cancer. And all of a sudden I got diagnosed with stage 4 colon cancer. So I went from having no cancer to stage 4. And then they said, oh, and by the way, it spread to your liver. So I went through chemo. I went through about 4 surgeries. Everything went well. Back on chemo now. So I'm kind of what I'm calling on my second marathon. So, I did the first line of treatments and now I'm on the second one. So I've kind of sort of gone around the track once, as I said, and now I'm going around a second time. So, I kind of have to agree with Eva's comments about delays in CT and MRI scans, but I also kind of share Alan's experience. So for me, things seemed to go fairly quickly once I got the diagnosis. Like they had me on chemo. They had a plan in terms of what they're going to do surgery wise, and I had home care come to the house. I had a PICC line, so they came to deal with that. So that kind of went well. However, I did experience a few things. So the big thing is getting delays in CT and MRI scans. So it seemed like in some cases, I could get a CT scan inside of 4 days done. And in other cases, it seemed like it was like a 6-week wait. So I think there's a lot of variability in the system, and the variability could be between cities, it could be between provinces. So I think what you might find is inconsistent across the country, where some people are getting like really good care and other people are not. And so that's definitely something. One of the impacts, the downsides that I see when you delay a CT or an MRI scan, ultimately what that's doing is delaying a treatment decision.
Correct.
So if the doctor, if you go for a CT scan on Friday, the doctors get the information, they're like, okay, we're going to do this treatment, or we're going to do something else. They can have that conversation on a Tuesday. If your CT scan is delayed 6 weeks, well, in 6 weeks, like that treatment decision is going to be made 6 weeks from now, right? So there's a downstream impact there. And I remember sort of at the beginning, like I said, for me, I seemed to be able to get CT scans pretty quickly done in the beginning. But I remember sitting in a doctor's office, listening to the secretary on the phone with a patient saying, the current wait time for CT scans is 3 to 4 months in Ottawa back then. So I felt blessed, or that I was able to get mine done so quickly. But it's definitely having a big impact on people, and often what people don't understand is that has a very heavy toll on people's mental well-being. The other thing I noticed, just anecdotal story. So in Ontario, we have a program called Telehealth Ontario. So what that is it's a 1-800 number you can phone. You can talk to a nurse 24 hours a day. And we've used that system many times in the past because it saves having to go sit in an emergency room for 8 hours, right? So normally we call them, and within 10, 15 minutes, they call us back, a nurse calls us back and explains everything, and we're clean, we're good. Settles us down. I called during, when was it? It must have been February, I guess, when we had, like in Ontario, we had a big lockdown. And I got through to telehealth, and they're like, okay, we'll have a nurse call you back. I'm like, great, because I was having a side effect with one of the surgeries. And they said, she should call you back within the next 8 to 10 hours. And I was shocked. So, and that's because everybody was phoning with COVID.
Yes.
So that was a big thing. I'll make a few more quick points here. Surgery recovery. So I was in the hospital for lengthy stays for two surgeries. One of the things I observed was stress on the nurses. So nursing staff, if you have nursing staff that are working on the floors and they specialize in liver surgery or what's called HPV, so liver, bowels, and all those things, that's what their specialty is. All of a sudden they're under stress of having to be moved to a COVID unit or to be moved to a different area that they're not familiar with. And likewise, you had nurses that were operation room nurses who were being put up on the floors to treat patients who were recovering from surgeries. And again, they weren't trained, they weren't really knowledgeable. So I definitely could feel like this tension or stress in the nurses as they were trying to just sort of absorb the various organizational changes going on in the hospital. Consequently, it takes longer to recover. The other thing is it takes longer to recover in the hospital when you're alone. So COVID restricted visitors coming in. And I've shared rooms with many people who were struggling in the hospital, like even just to go to their backpack and get the cell phone out of the backpack for them. Often I'd get out of bed, I'd like go over and I would help out other patients because, whereas normally a family member would be sitting there.
Yeah.
So I think people really who were in hospitals were struggling. The other thing I observed was you're sharing a room with somebody and they're having a FaceTime conversation with their spouse and they're discussing end-of-life care, funeral planning, and that type of stuff. And these are conversations that they would normally have in private. but now everybody in the room is listening in on it. So it was quite sort of tough listening through some of those conversations. And again, you know, they don't have a family member there to help them out. Second last thing, sorry, I'm taking too much time.
All right, no,
I did put some
very
thought
important story, Gary.
So in Ontario, they had various lockdowns as they did in other provinces. So often I was housebound. So I couldn't go visit a friend to chat about what I was going through. I know this sounds silly, I call it Home Depot therapy. So often I will go to Home Depot and I will just walk around looking at tools I should be buying that I don't need. But anyway, you know, just so I couldn't do that. You couldn't go anywhere. The malls were closed. Everything was closed. So you're just stuck in your house trying to deal with this illness.
May I build on that, Gary? Because I think there's a real theme to what you're saying. And this is what I call the psychological and emotional stress. Was there any care available to you in the system? Would that be a gap? Might you identify the need for psychological support throughout this time?
So
sounds like you found your own in Home Depot. But...
So, and I was going to talk about this a bit later, but so in the Ottawa Cancer Center, so they do have I'll call it a team of people that offer various services, and one of them is psychosocial support.
Right.
So yes, there's a social worker, and I would talk with her every 2 weeks and sort of help untangle a lot of those thoughts. So that was really good, super positive. But then I found out in discussing with other family members who had other relatives that had cancer, they were never told of those services. They had no clue. You know, they were told they have a skin cancer and they struggled mentally for months and months trying to sort through that. And I'm like, well, didn't you talk to the social worker? And they're like, what social worker? So I think there are services.
That was a gap.
Things out there.
Yes.
But not everyone is told about it. And sometimes you kind of back into these things or you stumble across them. And I have some more examples later. I did have one final thing about the effect of the pandemic on me anyway, was that my wife works in the hospital, which is great because she can explain what's going on. The problem though is she can't work from home. So she comes home from the hospital with the threat of having COVID on her or having COVID. I'm in the house with a weakened immune system. So we had to take extra special precautions. Like she'd come home, she would put all her clothes in a basket, wash it separately. We would stay apart as much as possible. And just because we're just, you know, extremely nervous about her bringing COVID into the house. So I think a lot of people who are dealing with these diseases, and if they have family members who are what I call like frontline workers, people who can't work from home, who are especially dealing with people that have COVID, then it really adds what I call the icing on the cake to the situation. So
great. Gary, thank you so much for sharing in very fine detail. I have one last question for you, and then I'd like to go to Natalie because as a nurse, I think she can really present a side of the story that builds on yours. Did you get a call back from Telehealth Ontario? You said between 8 and 10 hours before someone called you.
No, we didn't. Well, sorry. We told them to never mind, and we found we ended up going through the there's province of Ontario. They kind of contract out some nursing services to patients.
Yes.
So we ended up calling their help desk, which offers a 24, like an after hours nurse. So we talked to them, and that actually ended up being a better solution for us because that nurse walked us through, sorry, I shouldn't say us, it walked my wife through how to change the dressing that was on the side of my stomach where the surgery was done and sterilize it and reapply.
Very interesting.
You know, the dressing, like so it was walking us through over the phone, right? It was pretty good. So that turned out. But I guess the thing there is if families were just used to calling telehealth for a quick 10-minute phone call, they got clarification that what they should have done in Ontario anyway was have two queues. So if you're calling about COVID, we're going to put you in this lineup over here. COVID, people are training COVID. If you're calling because your kid got bit by a snake or a spider, or your child has a fever, or somebody like me, then you go in a different queue. Instead, they had everybody in one long 8 to 10 hour queue. So, and if you go into the emergency room at a hospital during COVID, that's a totally different situation. So.
Gary, those are all wonderful suggestions. I'm going to ask you to hold your thoughts there for as we bridge. I want to go to Natalie, because as a nurse, I'm sure you had a very special perspective on all of this.
I have a very special is actually it doesn't really describe the experience of what living
fair enough
with what's been happening right now. To add on Gary's point, Gary, we're all guilty of it. Retail therapy became my savior because we all needed to search for an outlet. And in full disclosure, I have a chronic illness, so it does not allow me to practice nursing in the hospital. So since the pandemic, I've been working remotely from home. So I hear everything you're saying. I hear and I feel the challenges, because there's a sort of a level of disconnect and a feeling of isolation that you do have when you're in this bubble that I call the COVID bubble. For our oncology patients at the Jewish General in Montreal, we actually, within the first 2 weeks, launched an oncology COVID clinic. So not am I only the nurse navigator for the colorectal site, I'm also one of 3 nurses that runs an oncology clinic for COVID positive patients. So to go, excuse me, to go with the theme of, there's a feeling of abandonment once you got that diagnosis of having a COVID positive diagnosis, and then the treatment was just stopped. And patients were reporting they felt abandoned because, well, where am I now with my treatment? There's a delay. I know I'm scheduled for a CT scan that was next week, but I can't have that scan because I'm positive. I'm not allowed back in the hospital. And every day the frustration mounted, not only with the patients, and that was hard to kind of articulate. We as professionals felt the frustration equally, because we know the delay meant there could be effects later on down the line. But daily, actually sometimes hourly, modifications were going through the system with updates of protocols from Santé Publique, from Health Canada. So we couldn't even catch our own breath to keep on top of what needed to get done. The delays that occurred, yes, they were very unfortunate. This whole the whole COVID is just a very catastrophic occasion that happened. But what I've grasped from it is it actually taught us new tools on how to communicate with patients better.
Right.
This virtual format, it's been a lifesaver. The challenge with it, yes, I have patients that didn't feel comfortable with me being invited into their private space, their home. They didn't want me to see it. They thought maybe there would be some judgment about what their home looked like. Some people didn't have the technology to get online so we could have this visual conversation. And I had to respect that, those instances. And, I had to get comfortable myself with just using a phone, because I'm a tactile person. I like to see a person. I like to feel the patient. I think that's how we connect, because it's just human nature. But it forced us to think outside of the realm of what we're used to practicing and develop new ways quickly.
I'm going to ask you, Natalie, to hold your wonderful thoughts on that. I do have a question about, would you say that across that continuum, prevention, diagnosis, treatment, survivorship, end of life, was there part of that continuum that was more or less impacted than others, in your opinion?
I want to say prevention. I feel we missed a lot. And I know some patients, they even, came back to me after, once they did get their official diagnosis, and they were honest. They said, I was afraid to go into the hospital. I knew something was wrong, but I couldn't put myself there because I was out of fear of catching COVID and then bringing it home to a frail family member. So I know, going with what Eva said, I know there was a huge segment that was missed. Could we have done better? I don't know. It's hard to say.
Thank you so much, Natalie. I want to make sure we hear everybody's story before we get into the next question. And so, Mana, may I ask you, in terms of impacts and across the system, what did you personally experience?
Well, I was diagnosed in October 2019, so it was pre-COVID. But I feel like I'm dealing with a whole bunch of other issues in our system. Maybe because I am, younger than 50. I was diagnosed at 42, so it was a real challenge trying to get diagnosed at that age. In total, like by the time my symptoms got really bad, it still took 9 months, right? So it was a long journey to diagnosis without COVID.
So then, may I ask, when were you diagnosed?
October 2019.
Okay.
Yeah, that was by colonoscopy, and then.
So you were just entering the system as the pandemic hit.
Yeah. Okay. So yeah, even without the pandemic, it took that 9 months to get there for me. And then after that, it was another month before surgery. So, it was a long wait. It was a large 14 centimeters, and still it was a month. And then after that, it took 3 months before chemo. And after I had the surgery, everything went to pathology. They found a metastasis in my liver, and it was obviously a stage 4 diagnosis, still 3 months, right, before I started chemo. So
you have said that the COVID inhibited was the result of that?
I think so, because it was really before everything came down and before the pandemic was announced, right? So like everybody knew of the COVID-19 and everything, December, January, right? But my chemo didn't even start until February. So the first cycle I had was normal, right? Like I went in, I had my husband and my sister with me for the first cycle. And then after that was when COVID restrictions came in. So then at that point on, it was, I was on my own. I think probably one of the worst things for me was security, right? So go to the hospital, parking lot, stop, why are you here? You got to say cancer, right? And you have to deal with this reaction from this person looking at you and feeling sorry for you. And then the next stop, why are you here? Cancer. And then, 6 times until you finally get to where you need to go. So you got to tell every single stranger on the way why you're there and give them your personal health information, because you have to, right? Otherwise you have no place being in the hospital, because nobody was allowed to be there unless it was for a good reason. So that part of it was psychologically, it was really hard for me. And I remember I can't remember which cycle it was maybe 2 or 3. And they had nurses in the cancer care clinic who were from the unit where they were doing the colonoscopies, endoscopies, and all of that, because that unit was completely closed. Nobody was there. Like no screening, nothing was going on, right? And like I live in a small community, and like even still, like we've had very few cases of COVID here. And when there's a diagnosis, they get sent to another bigger hospital. So the whole system was really like, it was just paralyzed, right? And for no good reason, in our opinion, because those patients weren't even being treated here. So why was that unit closed, right? So we missed all of those like screening procedures for no reason, right? But because all these decisions were being made provincially, didn't matter what community you were in, the rules applied.
Silos.
So, yeah. So yeah, I also experienced, like, my husband works in a school. We didn't have any school shutdowns. So he'd go to school, right, do what he had to do at school, and then come home, same thing that Gary was mentioning, take all his clothes off out of the hall and, you know, put them in the laundry and do them. And, you know, we didn't really know that much about, you know, children in COVID at that point. So it was like, you know, kids are germ factories, and, you know, having the compromised immune system from the chemo it was pretty intense, just
very
kind of
stressful.
Yeah.
Nana,
so, yeah.
Thank you so much. I just, I mean, it's an amazing, all of these stories are incredibly rich. And I want to make sure that we get to Corinne and Hannah, because all of you I can see are bursting at the seams to provide solutions. And that's where I want to take this quickly. So, but Corinne, please share your story with us. So we, especially all of them are, all of you are amazing sharers, I have to say.
Yes, thank you. Yeah, this is, this is great, heartbreaking and great at the same time. So YAC, like Young Adult Cancer Canada, just so everyone knows, in case you don't, it's not solely colorectal cancer or colon cancer, even though we have a big number of young adults in our community who are living with that type of cancer. But we are national. So I think a lot of what was said already was very much illustrated. So I talk with our community members, young adults, online every day. So because people were in different provinces, I think their experiences were quite varied, from what Cheryl Ann shared to Robin, to Gary, to Mana. I've heard all of a mix of all of that, but I think Mana's point was certainly a reality for us. So young adults, delayed diagnosis is a reality for young adults outside of COVID. So I think a lot of people kind of fell between the cracks or had issues. So I've heard stories of people saying it took a year before they actually were diagnosed, and it was not solely COVID related, but more because they were young. So we've seen that. So those are certainly things we've observed. And what was mentioned earlier, the psychosocial piece. So I think within our community, as we know in our healthcare system, our psychosocial workers and psychologists, they're usually overworked like most of our healthcare providers. And so they don't see every patient. They really don't. So I think in a time where there was so much uncertainty, that was certainly a big impact that we felt very strongly in our community, and had to adjust on how we could support the young adults connected to us, because we felt that their anxiety and their stress levels were quite high, with very little access to some support, plus everything else that everybody's mentioned. So I want to elaborate more for now, but these are some of the observations we've had in the last 2 years.
Thank you for sharing that. And I do want to, both for Corinne and Mana, acknowledge that I think there was particular impact on early onset colorectal cancer patients. You're right, 100%. It would be, I suspect, easier to diminish, oh, you're young, you don't have it, which is already something you're dealing with. So thank you for bringing that point up. I think it's very meaningful. Hannah, I'd like to finish this question with you, and really just the impacts as you experience them in the system.
Okay, so first, I just want to mention, the fact that colorectal cancer, is probably the most preventable of cancers. Having this, that's a huge thing when prevention is not even like a factor. As I couldn't agree more with Natalie, that prevention is definitely, if not the biggest, one of the biggest lacking factors pre-COVID. So during COVID, even more so, You know, and so we can only imagine without that, you know, once you start to feel the symptoms, you're already at a later stage. And I share, Mana, your, you know, frustration and your experiences. I was an early age onset as well. I was diagnosed at 38. And it took me 3 years to get that diagnosis. So it's frustrating. I can't even imagine. I probably wouldn't have made it through COVID had that been, you know, had that been my experience during COVID. So very, very frightening. But what I really want to sort of drive home the point, everybody spoke so beautifully and like really touched on some, you know, all the factors that everybody has been experiencing. But one thing, you know, as a social worker, so I've been working as a social worker in the medical system for about 15 years. So for me, what I've noticed pre-COVID, you know, is the fact that the support services around the healthcare system. So, you know, when you talk like the disease and dealing with, you know, the doctors and the disease and everything is very clinical, but it's all the periphery services that have been lacking. So we're talking about nutrition, and we're talking about, you know, social work and psychology, and all these support services that people need in order to get through the disease, in order to thrive, in order to minimize or mitigate the, you know, the side effects of treatments, etc. Those are the things that we've been hearing from patients that are just lacking in droves, you know, and I have to really commend, you know, community organizations like around us, for example, Hope and Cove, YAC, you know, all these West Island Cancer Wellness Center, you know, a whole across the country, because the way that these services, these organizations have pivoted and been able to put things online, you know, entire calendars, monthly calendars of wellness activities, etc. You know, has really made a huge difference for so many. The isolation has been another massive issue for patients. As you said, Mana, you know, you got to have that first, you know, chemo with your family there. And then that was it. And it's leaving people who are, you know, sometimes heavily medicated during treatment to have these conversations with their nurses in the treatment room or with their oncologists if they have a bad reaction or whatever. It's a very hard thing to manage on your own. So these are the things, it's really the support system and the support services that have been majorly impacting the patients and, you know, are contributing to poorer outcomes, I would think. Yeah.
Beautifully said, Anna. Thank you so much, particularly from your perspective as a social worker. As I said, thank you all for sharing your story so deeply and so beautifully. I know that what we want to do now is bridge from your experience into what are we going to do about this? And that is a big conversation. That conversation I'd like to break down into a couple of key questions here. And I want you to think about what can we do now? What can we do now, particularly to relieve the backlog, that pressure cooker of explosion that is sitting there? Eva, you so beautifully outlined. It's just sitting there, and we need to do things now. There's lots of things that the system can talk about for change, but those are 3, 4, 5 years out. Let's talk about today and some of the thoughts and ideas that you have based on your experiences that can relieve some of these surgical backlogs, that can pick up the ball again on prevention treatment. Is there someone who would like to speak first? Or yes, Hannah.
Sure. So, I mean, I've heard a lot about the idea of opening up, and I think they've even done that here in Quebec for sure, is some private, you know, some spaces in private clinics to sort of, you know, offload some of the more, you know, diagnostic testing, things like that, you know, and I think that's a phenomenal idea. If we can get sort of the private and the public to collaborate, you know, provide incentives, you know, government subsidies, incentives to some of these private clinics that are also struggling, of course, everybody's struggling in COVID, so that, we have the resources there. We have, whether we want to say it or not, we have a bit of a two-tiered system. So let's use it. Let's use the resources that we have. Or training other healthcare professionals, primary physicians, for example, to do diagnostic testing so that you offload that and you provide them, you allow the family physicians maybe to get more involved during the cancer care trajectory, so that oncologists aren't like sort of the end all be all of everything and have to kind of shoulder all of it, as well as surgeons, alleviate a little bit on the hospital staff so that they can, we can triage properly and use the resources that we do have, because I think it's really an allocation of services,
Yes. Yes.
in a big
and
way.
I build on that. And I love the point about the engagement of I see your hand up. Thank you. The engagement of other healthcare professionals in this momentum. Let me choose that word. I worked in the pharmacy industry for many years, and all of a sudden there was a fight at the beginning of COVID for vaccination by pharmacists, which of course ultimately happened. Has anybody here had experiences that are not with other allied healthcare professionals supporting them that were not oncologists, that were not primary care physicians? Is there other professionals that supported you in your journey? Robin, yes.
Through my union, the union at my work, there was a care path is the name of it. And it's an oncology nurses were able to phone. However, so I had an oncology nurse who could phone me by way of social support for a period of time, a few months. But then because of COVID, that service was slashed too. So suddenly that stopped. So that's, I'm assuming it's sort of a private or a nonprofit kind of organized system, but all of those two also were cut. So for example, the Canadian Cancer Society had a peer support mentorship program whereby people could be matched with people with the same stage, grade, or other features. And that peer support program also had to be canned because there was so the hard downturn in the economy, there weren't the same level of contribution. So those kinds of services, charitable services that were support, physical, one-on-one verbal support services for cancer patients were also lost, secondary to COVID. So it just what it teaches us, I think, is how those excellent satellite services are so dependent on donation that they can't function without more hard funding.
Yes, thank you so much. Eva, I want to go to you. You had your hand up, please.
Thanks. Hannah did speak to some of what I wanted to mention, but I think one of the main things that we learned, and maybe the COVID helped us to reflect, is, is there always a value to having to schlep and go to the hospital every single time? Not always, and so some calls were, if you're just going to go and be in front of the doctor for 15 minutes and he's barely going to look at you in the eyes, and then it's next, that could have been done on the phone, right? So I think that also when you speak to patients and families, they would prefer, especially when they're not living right next to the hospital, to get services as close to their home as possible, so in the community. And what we saw with COVID is that it is possible to deliver some services in the community, with delivery of medication to your house, with the pharmacist that can take a greater role, with telehealth services, for example, with primary care providers doing a little bit more, and so I think that we really have to rethink our idea of the healthcare system as only the hospital, and think, what can we provide in the community that would actually benefit patients? Is there really an added value to having the patient travel for an hour or more? Whether if you're in an urban center, it's because of traffic, and if you're far away, it's for other reasons. But that logistics of traveling and everything, it's not always necessary. Sometimes it is, but sometimes it isn't. So I think we have to think about that. And the other thing is, what else can we do? Like, can we do home prevention tests for the FIT test, for example. Why not? It's been done elsewhere, you know? And so I think that we really need to think outside of that hospital box in our minds for the healthcare system, even post-COVID, you know, maintain that telehealth, not just during the pandemic, but even once hopefully this passes, you know, to keep that for some situations and to do as much close to the patient's home as possible. So I think that would be good. And then even now with liquid biopsies that are, you know, soon going to be more on the market, and there's a Canadian organization now that's offering it, that I think that that'll help us to really not always have to go to the hospital, because, you know, whether it's COVID or something else, there's always a risk of other stuff at the hospital. Is it always necessary for patients to go there? You know, so I think that's one of the main takeaways. And then lastly, I would just add that because all these services were suddenly halted, patient advocacy groups and, you know, community organizations really had to step it up. And, you know, we represent like over 65 different organizations in Quebec and in the rest of Canada. You know, Colorectal Cancer Canada is one of them. And they really stepped up to fill those gaps, you know, whether it be psychosocial support or wellness or just breaking that isolation that patients felt. And so I think that another element is that, you know, there really has to be a lot of collaboration and referral between the public healthcare system and these patient groups, because we can actually both complement each other and help, you know, patients and their families as they go, you know, through this journey and all the gaps that they might have.
Mm-hmm, mm-hmm. Thank you so much. Shell, I wanted to go to you because you did mention in your story that you had quite a bit of care at home. Is there insight you can share from that?
I did. I had home care. So I ended up having my surgery. I ended up with 55 staples in my stomach. So I didn't have a laparoscopic surgery. I had an invasive surgery. So I had home care to come in, and I relied heavily on home care as the liaison between my healthcare team and myself. I wasn't mobile. So one thing that we did face here at our Stronach Center was they stopped doing the porta-cats for the IVs. So they wanted to do a PICC line. And I opted to do oral chemo because of that, because they told me the infection rate was so high. I had a high infection rate. The inconvenience of the PICC line, not being able to lift for 6 months, all these other things. So that was one point I wanted to add. Due to COVID, that service was stopped here. So that made a big decision when deciding on what my treatment plan was. And luckily, the healthcare or the home care providers that I had in here were great as far as supporting me. If I had questions that they didn't know the answers to, they made sure to get back to me. I'm still friends with them now. I've been released from the home care program. They phone and check in on me still today. So we were able to build a bond other than just a healthcare professional, which is important as well. I didn't feel so alone being isolated. We were in a new town. We were in a new community. I didn't know anyone here. I'd moved away from all my friends, my family. My husband was working. My children were working. I was alone in the home by myself, recovering from this major surgery. The other point that I wanted to bring up was not having someone be able to go to the hospital with me through my chemo treatment was another reason why I opted for the oral. Because of my surgery, I couldn't bend. I was in a binder. I was not allowed to bend. I was not allowed to lift. With colon cancer surgery, I had bowel issues. I was having to go to the bathroom every couple of hours. So I needed support in that situation. So that's where the home care was able to help me as well. But going to the hospital, I would have been on my own. So that's where I think the disconnect came. So again, another reason why I made the decision to do oral treatment was because of my restrictions and not being able to go to the hospital and have support. So I think if we're there, I never understood why my significant other couldn't have a COVID test and come into the hospital with me. I never understood that. I asked every single day why this was happening. And again, recovering from surgery in the hospital, like Gary was saying earlier, he was hearing conversations. He was helping. I relied on my bedmates to support me. I couldn't get out of bed. I couldn't move around myself. I had to push a button and wait till a nurse came. Several times I'm sitting there in tears because nobody's coming to help me. I have to go to the washroom. I can't go if my family was there, I wouldn't have been humiliated, or humiliated is a hard word, but humiliated that they had to now help me. So there was definitely a disconnect that way as far as psychological and the recovery process, that I think that we could do better. Yeah,
thank you so much. I wanted to go back and build on Eva's points about things like fit tests, because really what we're looking at now is there's a whole bunch of folks out there who have not been diagnosed, haven't been able to access to screening. We need to fix that. We need to get on top of that now. So there's like, what are some of the simple things that we think we can do today to tackle that? Robin, you have your hand up.
I think the provinces, each province has to do this themselves, but they could allow fit testing to occur in people under the age of 50, which they don't permit now. So unless you find a way to sort of do an end run around to get a fit test or an FOBT test, you can't get one if you're under 50 years old. And that's now, knowing what we know about early onset. I too, like all your other people today, early onset case myself was 46 and still said, you're too young, it can't be real. So I waited 2 years to be ultimately diagnosed stage 4. So that's, which would not, I wasn't stage 4 when I first went to doctors, but they said, you're under 50, screening starts at 50, no scope for you. No matter how symptomatic you are, no matter how strong your immediate family history is. And I did get a positive fit.
Strikes me that there's a real need for education.
I still wasn't allowed to get a scope. So there's, I guess what I'm echoing what others have said is that young adults have a real hard time anyway, for COVID, apart from COVID. And that's something that needs to change. So if they could open the door to fit testing of people of any age, that would help catch these kids or help all the people that ought to be detected. As we know, the United States has Cancer Society has made 45 their screening age. We haven't done that here. That also needs to change.
Thank you, Robin. Gary.
Just quickly, so I think one of the things I think that needs to happen is improved or increased education to family doctors and to the public to raise the awareness about early detections and early screening. And the reason why is, let's say somebody comes in, they go for a colonoscopy, they pull the polyps out, they send them off. If there's stage 1 cancer, that is a much sort of smaller problem to deal with than all of a sudden finding out you have stage 4 and it's spread, right? Because all of a sudden, like now, if you're stage 3 or 4, now you're doing multiple CT scans, multiple MRIs, you're doing surgeries. So I know for myself, the amount of hospital resources that I have consumed in the last 10 months is staggering. If this would have been caught earlier, like way earlier, I wouldn't have been such a tax or a burden on the healthcare system. And then what does that mean? It means more resources in the hospital are available for other things. And the second point, I think Mana really touched on this a bit, was optimization of hospital resources. And I'm hoping that, I don't have a master's in hospital administration, but in terms of an operations point of view in the hospitals, hopefully the decision-making is distributed so that if they're sitting there going, who do we allocate the next CT scan to or the next surgery room slot to, that they can look in their particular community and say, well, we don't really have many COVID cases right now. Let's slot in these other cases. Whereas in another jurisdiction, another region, they may have a lot of COVID tests. So sure, they're canceling surgeries and redeploying resources. So I don't know if maybe that decision-making is already distributed, but it definitely needs to be. And that's, in my mind, something that can be done today.
Yeah, I was going to say redeployment is a very real possibility today. Thank you, Gary. I know, Hannah, you've had your hand up for a bit, please.
Thanks. Yeah, what I just want, I mean, you're all echoing, I think we're all really all on the same page, which is really wonderful. And that gives me a lot of hope for the future. But, something that you brought up as well, Anne-Marie, is, education. And I think that there's, just in terms of this disease of colorectal cancer, there's an incredible lack of education and awareness around it. You know, from primary physicians all the way down to, you know, the population. And as a result of that, family physicians aren't asking necessarily the right questions. Most family physicians aren't even asking about family history. Colorectal cancer can be highly hereditary, you know. We're not talking about, and then as a result, we don't really have access to screening tools. That's another huge issue. Right now, Colorectal Cancer Canada, my colleague is working on a family physician, on a program for the education of family physicians nationally. So it's really to educate, you know, the greater population and newer, older family physicians to the signs and symptoms of colorectal cancer, because, you know, the scary thing about colorectal cancer, one of the scary things is that the symptoms can be so explained away by other means. Hemorrhoids, constipation, all these things that are sort of like, they're not a big deal. But as a group, they're a massive deal. And so, you know, we're not asking the right questions. We need to educate not just us, not just the public, but professionals on the questions that need to be asked. And, you know, the difficult topics, you know, no one wants colonoscopy and the screening and the prepping and all this. But we have to get comfortable with these questions, and we have to get very serious with the level of education that we dole out, you know, from a very, very young age, you know.
Thank you so much, Hannah. Robin, I'm going to ask, if you don't mind, just to hold your comment for a second. Several of you mentioned the value of, I'll call them community groups. Mana, you definitely mentioned it. It was as a resource. Natalie, you mentioned it as well. In the absence of services inside what I call the traditional system, many of you reached out to community service groups, patient groups, etc. I'd like to just hear if there is a potential short-term solution through some of these kind of groups versus the quote-unquote traditional system. Any thoughts on that? Natalie?
Well, I honestly have to say these community resources, whether it be through our hospital, the Hope and Cope Foundation, whether it be through the CLSC, which is, you know, a government-run kind of facilitating program, I've relied heavily as collaborative partnerships with these resources to guide my patients pre-COVID and now during COVID even more. Because where there's an extensive wait time list to meet with a social worker or a psychologist, these resources have come into play to normalize the trajectory for the patient through cancer, the symptoms they've been feeling, the anxiety that they're trying to manage and cope with on their own. So for me, to go back to what Eva had said earlier, it's really about a hybrid collaborative partnership that we need to design now in healthcare.
Great, thank you. Corinne, you had your hand up too.
Yes, well, I think a lot has been said already, but a part of me feels like what the challenges and issues we had pre-COVID have been enhanced in some ways during COVID, of course. And one of those things is this collaboration we're talking about between community organization and our healthcare system and the institution itself. It's been a challenge. I've worked on both sides, and it's been a challenge. And I think, except for a few key people, which I think are here definitely on this call and others that I know, it has been difficult to make sure that our key partners and colleagues in our healthcare system know what community organizations are able to offer, know how to direct. So for us as community, we have a responsibility, I think, to make sure to share information and ways to send patients to us for various needs. But ultimately, it does need, I think it has to come from a leadership perspective. I think if leaders within our institutions, and not just the social worker and the nurse navigator and all of those people who are on the ground daily, sometimes it can be quite challenging to remember resources, to refer to patients. I think there needs to be maybe a bit more of a leadership initiative that can really allow for this true collaboration with community organizations, because I think they could relieve some of the pressure that has been put on our professionals, which is another, to me, a part of me feels, and not to derail the conversation, but a part of me feels like one concern I have when we think of solutions is I hope that our healthcare system is going to spend real time thinking of how do we take care of our healthcare professionals, because if we do not attend to that right now, they will not be able to continuously be there for our patients. So I think the patients and those providing for them, they're a team, and we have to focus on those who have been, as we know, giving a whole lot in the last 2 years. And again, some decisions I think need to be made, because otherwise I think we can come up with 1,000 solutions, but if nobody's standing to help deliver those, it might not work.
I like the point you're making, Corinne, because not only like we're dramatically behind on so many different things now too. So these professionals who've been already under siege now have to catch up. And that's an extraordinary pressure. I'm going to, Mana, I see you've got your hand up, and then I'm going to bridge to the next question. I'll let you have the final word here.
I just had a couple of comments just about, first, just the fit test. Like for me, I had a fit test and it was done, 9 months prior to my colonoscopy. So I think these tests, they're obviously super important, but what is the protocol around that test? If you receive a positive fit test and you're 42, does that mean you still have to wait 9 months for a colonoscopy? Because if you receive a positive fit test when you're 50 and 1 month, you get in way faster, right? So I feel like there's a huge issue with age equality, right? Like, why is it different for people who are 49 versus people who are 50, right? Like that, I think, is a huge, huge issue. And for me, I think anyone who is bleeding from their rectum needs a fit test, right? Like, why is that such a big deal for GPs not to be able to, like, why can't they just offer that? It's really not a big deal. So that's just my personal feeling about the fit test. And yeah, like it could fast track you for a colonoscopy, right? Like fit tests aren't the end all be all, but at the very least, it's a step in the right direction. I also wanted to just mention something that I experienced in, the smaller community that I'm in. We had a GPO system here. So it's the GP oncologist. I met with my oncologist one time through telehealth. That was it. And then from then on through my whole treatment, it was the GPO the whole time. So maybe that's something like learning from the smaller communities and how they work with their patients in the smaller communities. Maybe we can implement that in the bigger communities as well, just to take the pressure off of, the oncologists themselves or whomever, the nurses. I also worked, I worked with, I had a PICC line as well. So instead of going to the hospital and getting the nurses to do the flushing, I went to the public health. So that's maybe another sort of smaller community solution, right, to limited resources. So it's just a couple of things from a small perspective.
Small but mighty solutions. Thank you. Yeah. I'm going to bridge to the next question. And in the interest of time, because I sense that we could probably go for about 5 hours with this group, is I would like each of you, just one thing. The question I wanted to ask is, what do you think we've learned from the pandemic that will be useful for patients in the future? And I'm asking that question. I want you just to say one thing. We'll go around the Zoom to get that, because I think it's a beautiful bridge into some of the solutions that you've already started to put on the table. So Robin, I love your engagement in this. You've just been Such a pleasure to watch as you've been nodding so forth. Give me the one thing that you think we've learned from the pandemic that will be useful for patients in the future.
I think it will be the value of telehealth.
Value of telehealth. Excellent.
Patients have been advocating for that for years, and now that pandemic made it a reality, and now everybody can see how much more efficient it is than in-person visits all the time.
Awesome. Cheryl Ann, what's your one thing?
Along the same lines, the value of being able to, of our healthcare system to be able to think outside the box.
Yeah.
And not deliver traditional healthcare provisions.
Yeah. And would you say that's in the virtual world, the technology adoption, that kind of stuff?
Yes. Yes.
Okay.
Yes. Being able to, for cancer patients, especially, these are not feeling well. It's easy to have a call on the phone rather than having to get dressed and go into a hospital. Your anxiety is less. Just having to get dressed is tiring most days, right? So having that comfort, doing it from the comfort of your home, I think is a benefit for us.
Right. Thank you so much. Where are we? Eva.
I just want to build for 2 seconds on what Cheryl Ann said. And I think that thinking outside the box includes home care as well. Home care has, and community clinics were really, really underutilized during the pandemic. But what I wanted to say, my one thing was not that. So I'm cheating and I'm using two. But I think that's one thing that we really learned because of COVID, but that could definitely be applied to cancer, is the importance of having timely, up-to-date information to make good healthcare decisions. We don't have that. We certainly don't have that in Quebec because we've been waiting for a proper healthcare registry for like so many years, more than 10. But knowing how many COVID cases we had, how many people were hospitalized, how many people were vaccinated, we had all the up-to-date information to the day or 24 hours or at the latest a week. And if we had that for cancer, if we could say the colorectal cancer screening program is working and here are the stats, here are how many lives we've saved, here's how much it costs, to Gary's point, here's how much it costs when you wait for somebody to reach a stage 4 versus investing this much in prevention. And then, how much does a stage 1 cost the system? Much less than a stage 4. And so I think that having that access to timely data in order to make good decisions, I think COVID has taught us how valuable that is. And now we just need to apply it to oncology as well.
Thank you, Evan. I know you're an expert on data and we're going to bridge into that subject. So thank you for raising that. Brilliant. And by the way, you're okay to get 2 because you represent 65 organizations. That's fair. Gary, what is the one thing that you think we've learned from the pandemic that will help patients in the future?
Building on, okay, I'm off mute. Good. Building off what Robin and Cheryl and said, the use of technology, but I do think there has to be a balance between, you shouldn't have 100% Zoom calls or 100% in hospital or in doctor's office visits. So there has to be a balance. So often I have a Zoom call with a doctor. The doctor is half an hour, 45 minutes late. That's okay because I'm sitting here in front of my computer doing other things and paying bills or whatever, and he can dial in whenever he shows up. It's fine. So that's better than me driving to the hospital and sitting in a waiting room for 45 minutes with a bunch of other infected patients. So that's huge. The second thing on the home care side, absolutely right. So I'll tell you a quick story. I had when I had my liver surgery, they had what's called, I think it's called a JT valve or a JP valve. It's a drainage bottle so that got removed. So the home care nurse would come to the house to make sure it was healing properly and everything. So near the end, the home care nurse called me from her car with her cell phone because I could see her seatbelt on and everything. And she asked me to grab my webcam here and hold it up, lift my shirt up and hold it up and look at the wound.
That's awesome.
And I held it really close and she's like, okay, yep. She goes, I can tell it's healed very, very well. There's no need for me to come to your house. And then she discharged me. And she did that, whatever, from the parking lot somewhere. But I thought that was a great use of technology, and yeah, everything healed fine.
Brilliant.
So, it saved a home care visit to the house. So there's ideas like that, I think, that are worth exploring. I was blown away that we did it that way. I thought this is really bizarre, but it absolutely was effective.
Yeah, thank you for sharing that. It's a beautiful example. Corinne, what's your one thing?
Oh, like I won't say technology because everybody said it. I'll say like a part of me, I think creativity, in the sense that I think there's privileges, or it's when you work for a small organization, you can make a decision and the next day you implement it. But I know in our healthcare system, for having worked for years in hospitals, sometimes we had great ideas that took about 3 years to be implemented for all kinds of steps and bureaucracy. And I've seen pivots as well in our healthcare system. And I know it was not perfect, but there were amazing things being accomplished by people who had to think outside of the box. And I think that's a strength. And I'm hopeful that we can build on, okay, maybe not everything needs to take 20 people making a decision and 2 years to get to a committee of, maybe we can actually use that momentum to create different ways to work together. So I think that's a strength.
Yeah, thank you. I think there's a strong desire for that too. Natalie, I'll go to you.
What I learned, ongoing education. It's such a powerful tool. And to go back to previous points that were discussed earlier, a lot of my patients have actually come back to me and said, you know what, we keep coming back to the hospital because the family physician doesn't have the most up-to-date information about colon cancer. They don't know what to tell us. And they look scared to talk about the issue and embarking on a topic that they don't know how to guide us on. So I think, going with what Karine said, I think it's about finding creative ways to disseminate that information, whether it be through social media, like a forum on Facebook or Twitter, or the hospital itself as an institution has to look at more, not the traditional format of here's a pamphlet, but other ways that we can educate people so that they can advocate for themselves. Because I understand being a young adult and you're going in and you're saying, these are the symptoms I'm having. And like Hannah said, often it's just dismissed into, oh, it's a hemorrhoid, or it's not really taken as seriously as a 75-year-old who's going to sit in front of you saying, I have rectal bleeding. So I think education was the most take-home message for me.
Yeah,
it needs to be an ongoing thing. Beautifully articulated. Thank you.
I'm going to go to Mana, and then we'll go to Hannah, because I know that Hannah's got a lot of pent-up conversation in this space too. Mana, yes, please, your one thing.
I think my one thing is just being open to the idea there is more than one solution. Because I found with COVID, it was like there was one rule, one directive, and everybody had to follow that one directive. And I think that it didn't necessarily apply to every person in every community or every province or whatever, right? So I think maybe just having a wider lens and, tailoring those solutions to the appropriate audience, right?
Thank you. Thank you. And I think you brought forward some really wonderful examples of what a small community can do versus some of the big centers. Hannah, the last word on this one.
Yeah, so again, obviously technology, but what I'm going to say, something that's really become incredibly evident, as though it wasn't before, is that our system is so taxed and really just doesn't, it's a real pressure cooker. And what we really need to try and do is we need to create self-advocates. We need to empower patients, because our system, we're not going to all of a sudden get this massive influx of money going there to hire more people, to hire more professionals. What we want to, but ultimately what we want to do is have people take charge of their disease, understand it, be able to become active members and active, actors in it. They should, we need to advocate for ourselves, and not just that, but creating support within the cancer community, creating peer support networks within the cancer community, which is something that we're going to be picking up again, you know, and running with, because there's huge value in that. If I can't get in touch with my nurse, you know, because I'm having issues, you know, bowel issues, symptoms from my chemo or whatever, I'd rather talk to the person, you know, who's going through it as well, and they're trying different things. This is the value of peer support. And, you know, it's not just solution focused, but it's also, you get that empathy, you get that, you know, that real lived experience together. And that's what creates connections and, you know, and better energy and better outcomes. So yeah, for me, it's really peer support and patient self-advocacy.
Yeah. Thank you so much. Again, hugely articulate expression of all of these things. We've touched on a lot of what I call solutions as part of this conversation already, but I want to bridge us right into that conversation. And there's a lot written recently about a resilient healthcare system. So it's not about fixing what's there. It's about where can we start from scratch? Where are some of those places to begin to rebuild something new, fresh, innovative, that leverages a lot of the things that you have already communicated? I hope you don't mind, Eva, but I'd like you to start this conversation on the question really is, what does an ideal cancer care system look like? What can we do now? What are the solutions that we can start to put in place, either practically or from an ideal perspective, to get us to a more resilient healthcare system? And I think some of this begins with data. Never mind the technology conversation, begins with data. So I'd like to give you the floor for a little bit, Eva.
Thanks. So I certainly think that in order to not just be resilient, but you know, there's also this concept of anti-fragility, where you actually get better from randomness and from external forces, and not just go back to the initial state. That would be resiliency, right? And I think that the essential factor that's missing right now is measuring outcomes, not just measuring clinical outcomes, like that's doctors and nurses and everyone does that already, but it's measuring outcomes that matter to patients and measuring costs. And now I'm just simplifying what value-based healthcare is all about, but basically you have to measure the outcomes that matter to patients and the costs, not just the cost of one medication, but the cost over the entire trajectory of care, so that you can invest more in prevention, like we mentioned before, right? And I think that we're not measuring much, and we're not using these measures to make healthcare decisions, better healthcare decisions for patients. And we're not learning. For example, we tried the breast cancer screening program. Do we know if it worked in Quebec? We don't know, because we only have 2012 data for cancer. So we can't make a decision based on, oh, it worked really great, or maybe we need to tweak it. And so I think that by measuring quality of life improvements, by measuring the impact on patients, not just do you have cancer or do you not have cancer, but what else? Can you move? Can you walk around? Do you have pain? How is your anxiety? You know, how is your mental health doing? By measuring all of these things and then making decisions based on that, I think that we can actually not only have a more resilient healthcare system, but a system that constantly gets better as we improve the data, right? So right now we're making decisions based on the outputs only, but we need to be making decisions based on constant inputs and measuring, oh, well, what if we improve early detection? Do we get less people with stage 4 cancer? You know, how do we know that? We have to measure. And so I think that we need to really push for a culture of measuring outcomes that matter to patients, measuring the costs over the entire trajectory of care, and not just, oh, that test is very expensive, so we're not going to do it. We're going to wait until you have no other options, and then maybe. No, spend money on that test, and it might save you a month of hospitalization, which is much more expensive, and we don't have the resources. So, you know, but we don't have the data to make those informed decisions. But it's accessible. We know now with COVID that when there's a will, there's a way to measure anything and everything that we really want to measure. And so I think that that's really the key success factor that will make it that anything that happens, we can adjust if we just have the up-to-date information about it, and we can make better decisions that ultimately give better patient outcomes. And we should be making our decisions based on that and not what's best for the system, because we don't even have the data that backs that up. So that's my 2 cents about that. And lastly, how do we figure out what matters most to patients? It's a crazy concept to ask them. You actually take the time to ask people, okay, I'm going to take care of your cancer. I'm Dr. Vlaba. Okay. But besides not having cancer, like, what else do you want? Do you want to be able to work? Do you want to be able to garden? Do you want to be able to play with your dogs or your grandchildren? Do you want to have a good sex life with your partner? You know, what do you need from us? And then base your decisions based on that. And it's not that, you know, that doesn't cost anything. Doesn't cost anything.
Thank you, Eva. I knew you would so passionately communicate that. We're going to go to Natalie, but as Natalie is speaking, I want to ask all of you a question. How many of you are actually connected to a health system where you're getting data back and forth? For example, I'm part of one of the Toronto groups, and I get quite a bit of data back and forth. I want to know who gets it and who doesn't right now. But Natalie, let's go to you first.
Well, I just have a question for the group, and I think it's fascinating what Eva said, because I wholeheartedly agree. I think it's a matter of just having that, you know, open-end conversation with patients and finding out, how are you coping? How are things going? What's the quality of life? So my question to the group is, how do you feel about questionnaires? Because often we get the feedback is it's onerous, it's laborious, nobody really looks at it. The results just get shelved and nothing gets changed. So my question is, do you find benefit? Is it too much to ask you to, you know, before a clinical visit, before you walk in with the physician, please fill out this questionnaire? Or if it's emailed to you the night before your clinical visit, whether it be virtual or physical, please fill out this questionnaire. Is it too much to ask of the patient to do this?
Robin, I'm going to go to you. And I think Gary, Mana, and Cheryl Ann particularly could Corinne to answer this question. Let's start with you, Robin. First of all, do you get data from your hospital? And by the way, you're on mute. You're on mute, Robin.
Okay, I'd like to raise two. You've asked the question about what are practical and solutions for now. And I'd like to respond in answer with reference to what you just asked do you have access to a patient portal? Can you access your own data? I know the UHN system has a fabulous, Sunnybrook does too. My province, nothing. There's nothing at all. Not only that, I think that each province needs to have a patient portal, and it has to be interoperable across provinces, so that if you're in a car accident in BC, they can still see your data from your life in Saskatchewan. So that's one very important thing that could happen right away. There can be allowing patients access to their own health information will vastly improve all of what I've heard people say about the need for self-advocacy. It's really hard to advocate unless you know what your test results really were. So that's critical. So another factor I'd like to say, in my province, hip replacements are done as a provincial triage. So you are sent to whatever hospital in the province has the next opening for a hip replacement. I want to recommend that triage investment be done like that, be done for colonoscopies. So back to this, not waiting 9 months, not waiting 2 years like I did, that as soon as there's a suspicion, a person there's a central hotline, a doctor can phone and say, where can I get a timely colonoscopy for this patient? Oh, it's 5 hours away. Patient, are you willing to drive that far? Yes, I am. There you go. So that patients actually have an opportunity to do self-advocacy and access health services they desperately require to do just what we've said. We got identified earlier and then not cost our provincial systems megabucks. So those are my two recommendations: health portal for all Canadians, and second, better interprovincial triage of cancer-based services, diagnostic services like that. It can be done. It's done for other conditions. Let's do it for cancer.
Thank you, Robin. Natalie asked a really great question too, which is your views on questionnaires, the ability
For me, it's not too much. And again, I like the idea of an email the night before with other professionals like dietitians or whatever. They use apps that allow you to you do your COVID screening the night before, and also you can answer important questions like that. It seems to me that there's a great efficiency and cost savings in email-based approaches like that.
Great, thank you so much. Gary, may I ask for your comments there?
Sure. Actually, Anne-Marie, could you just answer one question? I get to ask you a question. Wait, what do you mean by data? Like whether I'm getting data, what data? Give me examples of the type of data.
Well, thank you for asking me. Everything from if I've had a bone density test, I get those tests. I get all of my recs online. I get confirmation of my appointments with my specialist. It's managing me versus, which allows me to manage myself.
Okay, I understand. Yeah, so I'm in Ottawa, so I use the Ottawa Hospital. There's a number of hospitals in Ottawa. Some of them use the same network, the same system.
Yep.
So my data is shared, I think, amongst 4 or 5 hospitals. And then there's other hospitals in Ottawa that use a different system.
Yeah.
So it's kind of like a network, if you think. I get all the information out of there that I need. I can go in, I review all my blood work. I can read the report that was done by the technician for my CT scan, where they, or the MRI, where they say, oh, well, your tumor was this many millimeters, and then I can compare it. But it is a lot of information, and sometimes it's tricky to get. And I don't think everybody is going to go to the extents that I do. And I know some people just sitting in the hospital, the nurse will say, well, do you have access to the online portal? And they're like, no. And then the nurse is like, well, do you want us to set it up? And they're like, no, I don't want it.
Yeah.
So not everyone is going to be interested in pulling data or their information from a website. It's just not what they do. And they do have apps that run on your phone. This is the MyChart system, which is made by Epic, which is good, but the apps are limited, right? Like really the full power is on the web. I had a quick question. So for the surveys, yes, I'm fine with surveys. We do surveys at work. And if you talk to anybody who's ever done surveys, you're never going to get 100% response rate. So you'll get some coverage, but not everyone, but I'm fine with surveys. Eva, I had a quick question for you. What you're talking about in the hospitals, is that a mindset thing where they don't want to measure, or it's just for them to measure anything is considered a trial or a study? Because in the like I work in the private sector, we measure everything all the time.
Mm-hmm. Exactly.
And if we're doing something and it's causing problems for our customers, because customers start complaining, then that's feedback to us. We got to go back and tweak something at the front end of what we're doing to change our behavior to get the outcomes we desire to keep our customers happy. So it's called continuous improvement. It's something that's been around in all kinds of other industries for decades. So it could just be a cultural, like a corporate culture thing in the healthcare system. I'm not sure, I don't work in that system.
So it's finally catching on, but that's a great question. So it's basically the quality improvement applied to healthcare. And some hospitals have quality improvement, but they usually improve processes. So we do measure process. We measure wait times. We measure how soon you get your surgery, for example. We do measure process things. But what's missing, and it is a cultural thing, to apply that customer-centric kind of approach of continuous improvement that's currently used in business for like a long time. In 2006, 2 professors from Harvard started, applying it to healthcare. And it's taken almost 15 years to really get a little bit of momentum around this concept of value-based care. But luckily, it is starting to catch on. But most patients that we talk to are surprised that these things are not actually measured. Everybody just assumes, of course they are, because when I buy something, the company knows everything about me, then why shouldn't my hospital know everything about me, even though I went to another hospital next door, right? So that sharing, you had touched on like the sharing between hospitals. It should be the hospitals, the primary care, your pharmacist, like your data should follow you no matter where you go. And more importantly, you own your own data. It's your information, your health data. So you should choose who you give it to, who you don't give it to, whether it's shared with researchers, but ultimately it belongs to you. And it shouldn't be super hard to get your own information. You should be as involved or not as you want to be, because also putting the burden, not everyone is like awesome and engaged like all of you here. And it's not fair when people that don't feel equipped, that don't have the personality to fight, like Hannah has those fighting gloves. Not everyone has that personality, and it's unfair to expect all patients to just gather all their data, go to 5 different places to collect their own records and then share that with, it's not fair. We need to make it easy for people to be as engaged as they need to be, and for them to have the information that they need to make informed decisions about their own healthcare. Sorry that I jumped in there, but thanks for the question.
And Anne-Marie, just to answer your question, for me, the ideal cancer care delivery system is point 1, soon as somebody's given a colon cancer diagnosis, they're assigned, I'll call it a cancer coach, or somebody who's going to sit there and say, okay, here's what an oncologist does. Here's what radiation looks like. Here's what chemo looks like. Here's what surgeries. You need to go to this website and sign up for a support group with Cancer Care Canada. You should do these. Here's almost like a to-do list or a checklist.
Here's your roadmap.
Yeah, like the family doctor should say, here, take this, do these 7 things. Because often, like I said earlier, what's missing is they don't know that there's a social worker out there who can help them untangle their thoughts. And so people are just not aware. And the second point is, and this is kind of coming back to again, what we do at work is, there should be a monthly review between the patient and the medical team to say, okay, what went well last month? What's going well this month? And if the doctor says, I'm trying to get you in for a colonoscopy or a CT scan, but everything is booked up for the next 3 weeks, how do you feel about driving 2 or 3 hours to get a CT scan done, down the highway? And my friend does this he doesn't have cancer, he's different. He drives 2.5 hours to a hospital in Kingston to get a procedure done because in Ottawa, it's too long of a wait. So I think if the doctor had that appointment, like if the doctor would tell the patient, here are the challenges I'm facing, trying to give you the care you need. Are you willing to drive 3 or 4 hours to go get this thing done or whatever? And a lot of people will be like, sure, absolutely, I'll do it. Like if it's going to save me waiting 4 weeks, I'll get it done. So that's my kind of again, a monthly review of what's going well, what's not going well. What are the challenges that doctors are facing? And if there's a shortage of surgery rooms or beds or whatever, and sometimes people are willing to do what they need to do to get the answers, to move forward. So.
Yeah, thank you so much. There's a lot can be learned from business for sure. In terms of goal setting. Hannah, I wanted to go to you on this subject. Again, give us some of the principles that you think can go into an ideal system, particularly and because you work in the colorectal cancer space, is there a difference between general cancer and colorectal cancer in terms of changes that you would suggest?
I mean, that's a really good question. And again, I think it speaks to education. I'm very big on education. I'm very big on knowledge is power. That's something that I would always say to patients, whether I was working in a hospital or whether I'm working, where I'm working now. The more patients know, the more they're informed, typically the better the outcome is, because they will, they will ensure that they have a personalized care plan that meets their needs, not just their physical needs, not just, the disease, but the gamut of the biopsychosocial approach. And that's the ideal approach for patients. I mean, I want to see a system where we're starting in elementary schools and we're educating children at really young ages about lifestyle habits, that the physical education includes nutrition and discussions about, so many children, my children in particular, also, my stomach hurts, people will feel their stress or their pain or stress or whatever through physical symptoms, psychosomatic symptoms. And then that just builds a lifetime of kind of chronic, I don't want to say chronic disease necessarily, but chronic symptoms. And then these inflammatory, these inflammatory symptoms can lead to further things, to more complex diseases. We have to start early. So we need a system that's working from like the very beginning, all the way through to old age, and to do this, it engages patient groups, educating people. Right now, we're working on some education modules because we want patients to be able to, for example, I've just been diagnosed. So what do I need to know? We want to put that information out there so that people, become as engaged as they can in their own care trajectory. Because again, I think we need to meet somewhere in the middle. We're never going to have a system that we think is like extraordinary and meets all of our needs. We have to kind of come in there as patients and patient advocates and really kind of like support the workers. And it's going to be like, it's going to really take the two sides coming together, which is why this, Ready for the Next Round is beautiful, because we're engaging all stakeholders. And that's really where the brilliance is. That's what's going to make it happen.
Thank you, Hannah. I'm going to put you on the spot, if you don't mind, is because there's been much said about community groups, and particularly patient groups being, I'm going to call them a force for change in the future. Many of these organizations are not well funded. They do not have the resources. They do not have the money to make things happen. Is there, in an ideal system, some sort of financial flow that needs to happen to better support community, to better support profile patient groups?
I mean, absolutely. They run on, whether it's fundraising or maybe some contributions from pharma or whatever. There's various sources of income. But that being said, I think that's where the beauty comes from. I think it was Eva who was talking about, sort of like the partnership that has to happen between public and private, and between these larger institutions that are so much better funded, and us, the smaller beings that have a lot to contribute, but if we don't have sort of the platform to do it, or we don't have the resources to do it, for example, Natalie and I are going to be working on some stuff together, super exciting. And for sure, we're going to be able to pool her resources, because she's part of a larger network than we are. So, it's really creating those partnerships. And that's why, these partnerships are really going to make the big difference. If we all sort of band together and we create these roundtables, these think tanks where we're all sort of contributing from our own, our own kind of, corners, and we all sort of come together in a common, we're all working for the same purpose, we're all working towards the same goal. So I think really we need to kind of latch on to partners and piggyback and do things like that, be creative.
Yeah, thank you so much. If you don't mind, Cheryl-Ann, I'm going to ask you, because you had I'm going to call it a relatively good experience. You talked about being able to be cared for quickly, and you didn't hit some of the hurdles that others perhaps faced. Is there things that you think a more resilient system should take from that experience and say, do more of this?
I would say, so to build on Robin and Gary's point, I think it's very important to have a centralized system. So I was dealing with I had one point of contact, and then I was dispatched to different areas. It moved very quickly and it was efficient. So I think if we could somehow combine our healthcare system to enact these different levels into one place and then dispatch from there, I think we would see a benefit. And I think that would in turn create a great resource, less stress. A cancer patient is already stressed enough once they get a diagnosis. So now I have to go and track down the information. I had no idea that Colorectal Cancer Canada existed Nobody gave me that information. I was searching Cancer Canada, and I came across this website. So being given that information out the door would have saved me a lot of legwork when I already wasn't feeling well. Mm-hmm. So I think that's very important. And again, that goes back to education. That goes back, or awareness for the doctors. So I think we're all pretty much in agreement. There are gaps. And I think if we can, roundtables like this are great if we move to the next step with it.
If we take it to the next step, right. And I think that's absolutely the goal. Thank you so much.
I know today I will be when I go vote, because I know.
Well, that's going to be my parting question to all of you. But I want to hear from Mana on this subject of, let's call them things that you feel need to be built into a more ideal system to support colorectal cancer patients in the future.
Sure. I think as a patient, you spend a lot of time waiting, right? And trying not to worry and wondering if something got done, wondering if someone did something that they said they were going to do. So I think it would be really helpful to have some kind of system that sort of tracked the checks and balances of your team, right? Like my oncologist says they're going to order a CT scan for 6 months from now. Has that happened? In my case, my oncologist ordered an MRI. The radiologist kicked back to that requisition, and there was no record of it anywhere. My oncologist was off on a leave, and it was gone in the abyss. I never, heard from anyone on it until I realized there was something off. And then I had to call my oncologist office and play phone tag, try and get a hold of someone. And it was a nightmare trying to figure out what was going on, right? So if there was some kind of system where I could check in and see, okay, it got sent, that radiologist from my hospital questioned the requisition, and now it's, waiting for a response. Then I could, call and follow up and see what happened. But, instead I'm left trying to call the hospital, see if they got the requisition, call the oncologist's office, trying to get my GP involved, right? Like just running around. So it's that just feeling like I want to rely on the system, right? Like I want to be able to rely on the system and just know that they're going to take care of me, but I can't do that.
Right.
So I think just with respect to the survey, I think timing is everything, right? Like when you send those surveys, do you send them right after we leave the hospital after our surgery? Do you send them while we're receiving treatment, after we've received treatment? Because, while you're going through this or after you just went through it, you're like, it's fresh in your memory and you're sort of fired up about what you just experienced. Like my experience in the hospital was horrific, even though it was pre-COVID. But I would have loved to have given some feedback on that. Interestingly, I spent some time in a hospital in Thailand, about a week. They had an exit survey when you left. So it's just like a hotel, like, well, how did you find your stay? What do you think we could do to improve? How would you feel if we had a salon in the hospital, right? Like stuff like that. It was really interesting. It was, of course, a private hospital, right? So they have a vested interest in how their guests feel, right? But I think the timing for the survey is really important. And also, who is the survey coming from, right? Like if the survey came from, say, my oncologist and she said, we want to see what's going on with young women in CRC. What's happening here? Would you be willing to fill out this survey so we can learn something about that? Then absolutely, right? But if it was just, a random survey that we're not sure what the results are going to produce and how big of an impact it's going to be, then maybe, wouldn't be so inclined to fill that kind of a survey out. So
yeah, thank you so much. That's beautifully said. Private healthcare can be a pretty interesting thing to look at, isn't it?
Yeah.
Natalie, your thoughts. We've got about 5 minutes left, so I knew this would take much. This group is just so buoyant; it's incredible. But Natalie, I'll final comments from you on what an ideal system might look like.
Where all of your voices are heard the way I was able to take that in this evening. Honestly, thank you for including me in this. It's hard being the professional because sometimes, as you've all echoed in different ways, there's a level of pressure on us. We want to meet the expectation, and it is our job to help guide you through the system. But unfortunately, there's not enough of us. There's only one of me for all of the tumor site of colorectal. So there's many people that I don't encounter. And I know they could have benefited from having me guide them through what the next steps were. I think it's just an ongoing process of having discussions open-ended like this, where we can get that rich information from all of you and then go back around the table and have that communication. I mean, I agree 100%. There's no purpose of, the timing needs to be right when the survey goes out, and there's no purpose of getting that information and having it sit there in a box, and we don't implement it, and we don't implement it correctly. It needs to reflect what your reality really is. So again, thank you to all of you for, being so open and forthcoming with the information that you shared, because it helps shape my practice, and I take it back and I maneuver and I spread knowledge to my other professionals that I work with, whether it be social work or the chemo nurses or even the oncologists themselves. Like, we need all of that rich feedback in order to shape a good experience for all of you.
Collaboration is a wonderful thing. Beautifully said. Corinne, I'd like to give you a chance to provide your comments as well.
Sure. A lot has been already said, so I'm not going to repeat everything. I'm in agreement with all of that, but I think maybe it's too idealistic, but to pick up on some of what Natalie just said. I would love if we could figure out a way to break this cycle, because patients go into hospitals and they get diagnosed and it's traumatic and they are in crisis, but I feel like our healthcare system is in this constant state of crisis and high levels of stress and demand and expectation. And it's really difficult to make decisions present and for the future when you are yourself in this kind of high stress and crisis mode. So part of me feels like we're running after our tails continuously. I don't know if there's a way to pause or to have people who are enough remote to look at what's going on and then to maybe think of ways to break this cycle, because I feel like we have been in this kind of system way longer than COVID era. And then our patients are coming into the system and everybody wants the best. So I think that's not the problem. I think people care and care a lot. But ultimately, a part of me wishes we could figure out a way to break the cycle, to maybe have clearer mind so we can make decisions that are going to be the benefit of everyone.
Thank you so beautifully. I am going to give the last comment to Eva, because she is somebody I admire and respect so much and represents so many great patient voices, is on the eve of an election and with change ahead. What is the one thing that you feel that we need to do to drive a more resilient healthcare system around colorectal cancer?
I mean, I talked about outcomes a lot, but I think we're involved in a movement that's starting now called People Before Patients. And I think that we need to remember that everyone is a person before they're a patient. And so humanizing that healthcare, I think, is going to be essential. Prioritizing prevention rather than like going towards a model that's predict and prevent instead of break and fix, which is what we're currently in. We're like, oh, it's broken, or you're not sick enough, so we're not going to take care of you yet. Like, there's provinces across Canada where you can't even access the most innovative drugs unless you're on your deathbed. You can't access clinical trials unless they've tried everything and nothing works. So I think we really need to have this predict and prevent model, like shift towards early intervention, like catching people early and giving the right people what they need at the right time. And I think that we need to do that by treating, people as people before patients. What I mean by that is not just treating the disease, but really aiming for wellness instead of sickness. We have a sick care system instead of a health care system. And I think that we really need to aim for wellness. And to do that, we need to understand what are people's goals and needs. And we don't do that currently. We're just trying to eliminate the illness, fix what's broken. But we should actually be trying, how can we make it a wellness system? A real healthcare system doesn't just fix illness, but it creates wellness. And so I think that it's a shift that has to happen. Like, it's a cultural shift. I think that, there's more and more ambassadors of that movement. I think that there's more and more people that are realizing that everybody really wants that. I mean, when you think about it, like, what would you want as a person? What would you like for your family, right? You want them to be treated like human beings with compassion. You want to be listened to and heard, but that needs to be included in how we make decisions now. And so I really think that if we want to close with something, I think we're on a good track, but we really have to aim to invest more in predicting and preventing and intervening early and giving people what they really need, but not assuming that we know what they need, because that's what we're doing right now. Like, decision makers and doctors who are like very close to God, like they know everything, but everybody's different. Even within colorectal cancer, it's not a monolithic like patient segment. There's very different needs for like an early age onset colorectal cancer patient rather than like a 65-year-old retired person. They both need help, but they need different types of support, different types of resources. And it's not a one-size-fits-all model. And so I think that with personalized medicine now, we need to increase that personalization of healthcare, not just with the drugs, but also with what resources, what questions we ask, and I think that we absolutely need to provide the information necessary so that patients can be as engaged as they want and that they can be empowered, but only as empowered as they want to be as well.
Thank you. As suspected, articulately, beautifully stated. Thank you for that. A couple of things is, I know that this has probably inspired a lot of conversation for all of you. You probably have a whole lot more thoughts. May I encourage all of you to reach out to Maria specifically, who was your direct contact. If you have other things that we feel that we didn't cover in the 2 hours we had, I know she would love to hear from you. We also have folks sitting behind the scenes. I should have perhaps mentioned that. Just some interested parties. And I wanted to share with those people that they can email us at jointheconversation@colorectalcancercanada.com. So for those of you who don't have direct access to Maria, but want to say something, please go to jointheconversation, all one word, at colorectalcancercanada.com. On behalf of colorectal cancer, I want to thank all of you for certainly making my day. This was astoundingly incredible session. Thank you for participating. Thank you for your time. And we will sign off now.
Thank you.
Good night, everyone.